I'm Dana Fillmore, Healthcare Marketing Manager at Gordon Food Service. I'm here to talk to you today about preventing malnutrition among COVID-19 person-centered strategies to improve quality outcomes. I'm joined by my Gordon Food Service colleague, Amanda Goldman.
Hi, my name is Amanda, and I'm the healthcare industry sales strategist for Gordon Food Service. I'm a dietitian and operator by background, and I'm excited to be with you all today. Our agenda today, we're going to go over several great topics. We're going to discuss the road ahead, malnutrition and isolation, the impact of malnutrition, some intervention strategies, along with some helpful resources. Dana?
Yes, so thinking about the road ahead, we want to think about the COVID-19 public health emergency and the resulting isolation that so many of us have felt and some still are. We're going to talk about how that may impact the prevalence of malnutrition of the older population. So first, let's look at just that sheer size of the 65 and older population. As you can see on the graph, from 2000 to 2018, there's a 35% increase in this population. And the light blue bars to the right show projections for continued growth. The population is expected to grow significantly. And looking further into the stats here, we see that a significant portion of the 65 and older population live at home alone, 21% of men and 34% of women. And further, research shows that 1 in 5 of them have expressed feeling lonely, and that's pre-COVID. And then enter COVID, and we had so many governments implementing local stay-at-home orders. Hospitals and long-term care, senior living eliminated or severely restricted visitors. Everyday social events were canceled, such as communal dining. Some are still canceled and coming back slowly. This compounds the loneliness factor. And we know that loneliness is associated with failure to thrive, including a higher risk of malnutrition. When you have social isolation and loneliness, there's an impact on the enjoyment of food. It's not as impactful. There's a reduction of enjoyment. Your appetite isn't there. In fact, they say you eat less meals in a day, and your diet quality suffers. Many research studies point to lower intake of protein, fruits, and vegetables. And that can be significant as you look at the malnutrition population. And malnutrition is highest in older adults. In fact, 1 out of 2 people 65 and over are either malnourished or at risk of being malnourished. And it gets staggering when you look at the prevalence among the different care settings across the continuum of care. You can see on the graph that up to 50% in acute care, 51% post-acute care, malnutrition prevalence. That's staggering. And even in the home setting with community care, 6 to 30%. On top of that, with the COVID-19 crisis, we also have the threat of food security. The pandemic has potential to increase levels of food insecurity in these vulnerable households. Number 1, inability to get groceries. The elderly have stayed home for fear of going to the grocery store, and they have less visitors that go get groceries for them. Some have a reduced income, which impacts groceries as well. There's been a disruption in community food programs. And the biggest disruption to that is the increase in demand at the same time where we're having maybe a little harder time finding volunteers. And 9 out of 10 Meals on Wheels programs have reported increased demand. In fact, 4 out of 5 of them said their demand at least doubled. Now, I want to put that in perspective for you. In Rockland County in New York, where the pandemic hit very hard, there was a Meals on Wheels program that normally does 8,000 meals a month. In the height of the pandemic, they did 20,000 meals a month. Demand has skyrocketed and it is disrupting the ability to get food from these programs. So all of this together, between the food security and the risk for malnutrition, it threatens millions of people, many of whom were already suffering. Some say the pandemic may add an additional 83 to 132 million people to the ranks of the undernourished in 2020, just 1 year. Now, it's too early to provide collective evidence. However, we do expect to see a spike in malnutrition. So, Amanda, can you pick it up here and talk about the impact malnutrition can have on the quality of life as well as the impact on our health system?
Sure, I would be happy to. Thanks, Dana. So we know that malnutrition increases the risk of a multitude of negative health outcomes. With malnutrition prevalent in all types of healthcare settings, it is vital that we're aware of these potential issues in order to help avoid them. Such outcomes include immune suppression and higher infection rates, increased incidence of healthcare acquired pressure ulcers, along with delayed wound healing, decreased respiratory and cardiac function, muscle wasting and functional loss, increasing the risk of falling, longer lengths of hospital stays by approximately 2 full days, higher readmission rates and higher treatment costs, equivalent to about $51.3 billion each year, and increased rates of morbidity and mortality. And it should be noted that protein calorie malnutrition, when it is identified, that these patients have about 3 times higher incidence of death. So speaking of quality of care, for individuals with pre-existing malnutrition, when they are admitted to an acute care location, the risk of falling and developing a pressure sore is increased by about 2 times. Additionally, they're more likely to develop various types of infections, including surgical site infections, along with urinary tract infections. And because we know that these patients are more likely to be readmitted to the hospital, it is especially important to provide early nutrition intervention, as that can help to decrease readmission rates by about 25%. So there are a number of research articles that are available regarding caring for individuals with malnutrition. One such study I was fortunate enough to be a part of from a research perspective. It looked at the impact of nutrition interventions and improving outcomes in hospitalized patients. We found that with early identification of malnutrition and subsequent implementation of dietitian recommendations, that there were positive results regarding overall care. Specifically, the results showed a decrease in length of stay by about 1 full day, a small decrease in readmission rates, equivalent to 0.15%, and with the implementation of the program, clinicians were able to identify patients with pre-existing malnutrition so that the actual diagnosis rates by physicians increased from about 3 to 7%. This enabled a more comprehensive care for a larger number of patients within that hospital. Additionally, an article was recently published in the Journal of the Academy of Nutrition and Dietetics, and it discussed the use of a supportive toolkit and how that can help to improve malnutrition in hospitalized patients. The toolkit supports implementation of a various number of quality improvement initiatives. It assists with identifying gaps in a malnutrition program, and it also provides a bunch of tools and resources that are available for dietitians as well as other clinicians. So thinking about some key points, the current healthcare environment has caused organizations to think differently about how care is provided, whether that is to patients in hospitals, residents in senior care settings, or individuals receiving some type of home care. We know that malnutrition increases the risk of poor health outcomes and also increases the cost of care to the overall healthcare system. Various factors exist that cause the increase, including the quality of care ones just discussed. Some other factors to consider, though, also include an increase in usage of supplies, medications, lab tests, various treatments, and labor in the form of human resources. We also know that organizations are incented to improve clinical outcomes, and senior leaders are focused on that as the government decreases reimbursements for hospital acquired conditions and infections, as well as penalizes those organizations for readmissions. Ultimately, organizational leaders must focus their strategy on preventing and effectively managing malnutrition to help improve the overall outcome of their patients. Beyond financial benefits, operators must also recognize the benefit of broadening their reach across the continuum of care as part of their strategy.
Exactly. Well said, Amanda. And so now that we've reviewed the risks of malnutrition, now let's look at how we can help make a difference throughout the continuum of care. We've got 4 key areas we'd like to take a look at: malnutrition programs and the interdisciplinary team, care transitions, community partnerships, and elevating the dining experience. Amanda, why don't you start with malnutrition programs and the interdisciplinary team?
Sure, thanks, Dana. So let's focus on getting started and what your next action steps are. These steps will be helpful whether you're implementing a new comprehensive malnutrition program or whether you simply want to enhance the one that you already have in place. With any new program or revision, it's really important to consider standard project management techniques. So, for the purposes of this potential nutrition issue, your goal is to improve quality of care by having a program that synchronizes recognition, documentation, and successful intervention of persons with malnutrition. It's critical to identify your stakeholders, determine a process, and create a timeline for training and implementation. It is also vital to incorporate a system for continued monitoring and evaluation. So let's now think about the team. Who will share your vision and help to champion the process? So it goes without saying that registered dietitians are a huge part of that team. But also, we need to make sure that we include nursing leaders, physicians, senior leaders within the organization, quality managers, staff members from the rehab department, including PT, OT, and speech pathologists, along with the clinical documentation improvement personnel and their coders, activity leaders when it's in a senior care setting, and then, of course, we can't forget about our community partners. Generally, a clinical nutrition manager or designated dietitian leads that stakeholder committee, but it's also important to be mindful of the continuum of care for the patient or the resident and who should be involved from both within and outside of that organization. So, regarding program effectiveness, it is crucial to ensure that adequate training for your multidisciplinary team that includes screening for both insecurity of food as well as nutrition screening when they're admitted, the dietitians completing a nutrition focused physical assessment when applicable, and also ensuring that they recommend proper nutrition interventions. It's also extremely important to ensure that through monitoring how you're going to maintain the integrity of your program. Such considerations include: does the clinical team document characteristics appropriately and consistently? Are physicians actually not acknowledging those recommendations and the interventions? And with the current pandemic, interventions including fortified foods, beverages that are high in calories, and supplements, those are especially important, which is why it's critical that everybody on the team is on the same page. You also want to consider: how are you impacting your readmissions and other clinical outcomes? And are you working with the CDI team as well as with the coders? Does your audit tool provide what you need? And you need to recognize areas of opportunity to see if you actually need to provide additional training so that your clinicians can improve their skill set along with their confidence level. And it also is very important to note that we need to make sure that we provide our data and that we look at that data and that we use it to make changes. With any program, it's not going to provide great results unless we make sure that we utilize that data to affect change. So now let's hear from Dana on incorporating nutrition as a core component of the Care Transition Plan.
Thanks, Amanda. Integration of nutrition considerations into care transitions is very critical throughout the entire continuum of care, from community care to acute care to post-acute care. Ensuring quality malnutrition care is important to ensure overall quality of care, as well as the financial aspects of quality measures. I'd like to point out for you some of the recent wording changes in the CMS reform of regulations that was a year or two or so ago that went so quickly on us. Anyways, the reform of regulations was focused on person-centered care changes, right? And they focused in on discharge planning. And I think that says a lot. There's specific wording that was used in this regulation as it relates to nutrition and discharge planning. You can see that it mentions the interdisciplinary team that Amanda just went over. It also mentions that discharge planning should include the nutritional status and referrals to local contact agencies for support services such as meals and groceries. And when you're looking at discharge planning and discussing things with the people you are helping, we've got some categories here we'd like you to take note of when you're doing that planning. And first, it's groceries. This is a big one. Think about when your patient goes home, if they're going home, will there be groceries? Who does the shopping for them? Did someone clean out the refrigerator when they were gone? And meal prep. Can the person prepare their own meals? Do they live alone? And if so, if they live alone and they can't prepare their own meals, what plans have been made to help until they are able? And what if they're going home with new diet recommendations, whether it's therapeutic or consistency modified? Do they need training? Think about somebody going home after newly being told they have to do a puree menu. This really impacts shopping and meal prep as well. And don't forget adaptive equipment. Talk about what might be available to help them eat more comfortably. Do they even know that there is adaptive equipment available? I mean, if the elderly who is having problems with dexterity needs the right kind of built-up silverware, I'm not sure everybody knows it's available. So make sure they do. That's your job. And make sure they know where to get the equipment as well. And last but not least is food security. In other words, as Amanda mentioned, screen for food insecurity. Quite often this can be overlooked as an issue only for people with low income, and that's just not the case. Especially as we've experienced here with COVID-19, it could simply be a case of somebody can't get to the grocery store for whatever reason it may be. And if you do identify a need here, it's your job to help connect the person to appropriate support services such as meal delivery or a local food pantry. I want to share with you this 2-question survey. It's called the Hunger Vital Sign. This is a validated survey that many healthcare organizations use to help screen for food insecurity. It's very simple. If you want to learn more, simply Google Hunger Vital Sign and the information is there for you to use. And as you think about care transitions and malnutrition, I'd like you to keep this acronym in mind, ACE. A is for assess, screen for food insecurity, work with the interdisciplinary team, the clinical dietitian to include a physical assessment as appropriate. The C is for connect, and this is definitely a large C. Connect people who need help. Collaborate and refer to your local nutrition programs. And now, if you find that the resources are lacking in your community, Talk with your team about hosting your own resources. It can be simple as a food truck in an area that does not have a lot of access to food. Food pantries, community gardens, farmers markets, community kitchens, or meal delivery to a targeted audience. Partner throughout the continuum of care and in your community to make these things available. And now let's look at E. E is for educate. Educate for long-term success. Nutrition isn't something that you can check off. It's a daily event that lives on, right? We need to reinforce the importance of balanced nutrition. And in this education area, be sure to include the primary caregiver in that education so they can work together on this. Moving on to community partnerships. This is part of the C in CONNECT for our ACE acronym, right? We have a guest speaker here today. Meals on Wheels of Western Michigan is a great example of partnering with local hospitals to assure local seniors get the balanced nutrition they need. Let's hear what Lisa has to say about connecting with local hospitals.
My name is Lisa Weidman, and I'm the Chief Executive Officer for Meals on Wheels Western Michigan. Our program is a large program covering both Kent and Allegan counties, and we touch about just over 6,000 seniors every year. So we began working with local hospitals about 2 years ago as a result of research being conducted nationally with Meals on Wheels programs and healthcare systems. And what we have found is that the research is beginning to show that Meals on Wheels programs actually impact hospital readmission rates. And so we've always known that we have an impact, but now there's data packed behind it. And so we started with an intern doing a master's level project at a local dietetics school. And from there, that blossomed into a research project we're still working on getting it off the ground. COVID-19 really put a little bit of a damper on it. But the research project essentially is going to be, what is the effect of medically tailored meals on heart failure patients and what the readmission rates are looking like as a result of that. And we do believe we're going to start to show some dramatic differences. We're going to be piloting a 3 meals a day program with medically tailored meals, which is essentially going to be a version of the DASH diet. And we're really excited about that. Another thing that we have found is that healthcare does not fully know yet exactly what it is that we do for the community. The fact that we're more than a meal. We provide a safety check and a social connection for those seniors. And so not only the food, but these other social determinants of health that really make an impact on how healthcare functions within their patients. And so part of our efforts has been to educate. And we recently, and I say recently, I think we're going into our 3rd year now, have partnered with a local healthcare system and their resident program. So their resident physicians going into family medicine are coming to our program, spending some time with our assessors to see the kind of screening that we do, the referrals that we make out in the community, as well as going along on a meal route. Again, because of the pandemic, we are modifying that slightly, but it has been nothing short of amazing. And the amount of knowledge and breadth of understanding that these soon-to-be family medicine physicians are able to really grasp what's going on with our program. And they all say, oh, I can think of 3 or 4 people right now that would just really benefit from your program. So the two combined have been really instrumental in helping us reach the healthcare community to really educate them, help them know why our program is so vital to their patients.
Thanks, Lisa. Meals on Wheels of Western Michigan is doing such incredible work. Your passion shows through. And your examples of working with local hospitals are motivating and proof that taking full advantage of the local resources and experts around you can be a very helpful part of a complete malnutrition program. Let's move on, and we're going to still be talking about community partnerships here, but I want to spend a minute on something called Community Health Needs Assessment. If you work for a not-for-profit hospital or have one in your community, this process opens up opportunity for networking and community partnerships. Not-for-profit hospitals are required to do a community health needs assessment annually. And in this assessment, they identify and prioritize needs of the community. And then, in order to maintain their not-for-profit status, they must devote a certain amount of funding to those needs. Nutrition-related needs are commonly identified, like obesity or diabetes. But malnutrition or food insecurity and access to healthy food only came up 13% of the time, according to a 2018 research study. However, what we want you to think about now, all of you here at different parts of the continuum of care, we need to think about if we will start to see a shift here and potentially see food insecurity and malnutrition showing up more. We're challenging you to be proactive and to start planning now. And now, Amanda, you've had some experience in this area. Can you add some of your insight here?
Sure, thank you, Dana. In a prior role, I assisted with the annual community health needs assessment for a large hospital system, and we did often find that diabetes and obesity were areas of concern that needed to be addressed. While these remain critically important, COVID-19 has demonstrated that malnutrition is ripe to appear as an acute focus area for at least the next few years. So now let's move on to our next intervention strategy and discuss elevating the dining experience. Dana?
Yeah, thanks, Amanda. Elevating the dining experience is a wonderful intervention strategy to improve nutrition intake. In fact, it might be my favorite one. Person-centered strategies really need to be highlighted here, and we need to make meals and snacks a pleasure rather than a task. So as we do that, we're going to have much better chance to see optimal intake and hopefully less malnutrition. So here, I'd like you to think of triple A. Atmosphere, promoting comfort and dignity, creating a welcoming and relaxing environment. That's so important. And assistance. Assistance is about empowering maximum independence and dignity. There's that word again. Elderly that have experienced loss of dexterity, hearing, sight, whatever it may be, giving them the assistance they need to encourage self-feeding is very empowering. And alternatives. Alternatives are about offering true choice and self-determination. And when we're speaking of senior living specifically, choice is about where, when, and what to eat. Providing delicious, nutritious menus that reflect your preferences, right? Including cultural and religious. And then for those on-site dining areas like senior living, consider expanding the options of where and when to eat. You can have kiosks, bistros, carts down a hallway, lots of different ideas. And this is especially important while we have restrictions in place and communal dining is still closed. It's important to get creative and figure out how you can still do some of this. So we asked Lisa to help explain how Meals on Wheels of Western Michigan provides choice and enhances the overall experience for her members.
When we began the program, it resulted because of us listening over the years to the needs of older adults and the fact that more and more there was a desire for choice, especially in the baby boomer generation. When we are losing our independence, maintaining choices in our lives is crucial. And oftentimes older adults do that by controlling what they eat. And so we believe strongly in that dignity of choice. It doesn't do people any good to provide meals if they're going to go uneaten due to cultural, religious, medical reasons, or just that's just how they eat. So that's the reason we started the program. We found clients not consuming the meals. And we know, you either love or you hate something, right? So that was the big reason that we implemented our first project. Way back in November of 2014, we started it on a little tiny scale of about 100 people that were getting a once a week delivery in the remote areas. And we really wanted to enhance their experience. And so why not start there? Why not start with people that are getting a once a week meal delivery? And it was so popular. The next stage, we rolled it out to more of our delivery routes and more of our delivery routes. And a year later, we implemented that program throughout the organization. And today, it serves over 1,100 seniors out of about 1,900 to 2,000 that opt for our program. Some of them want our traditional menu, but most of them, obviously more than half are opting for this choice program. And so they're able to take a look at a menu of about 25 to 30 meals of differing flavors, foods, combinations. We have vegetarian, breakfast, beef, pork, poultry, all of those different kinds of foods. And then the ability for them to see the nutrition. We actually put our nutrition right on that menu for some of the major nutrients that they're worried about, their doctors are worried about, their caregivers are worried about. So things like calories, protein, sodium, carbohydrates, fats, all of those things are incorporated so that they can make healthy choices for themselves. It's been very popular with not only our seniors, but the people that are taking care of them as well as their doctors. We have been able to utilize volunteers to help with the loneliness. Our seniors are just not connecting like they were. They're not even able to connect with their drivers the way they were because our drivers are knocking on the door, making sure that they're safe, leaving their food. And so those 5 minutes, 10 minutes that they've been spending are no more. And fortunately, the West Michigan community has really stepped up with volunteers. And so we have volunteers calling our most isolated clients and checking in with them, seeing if they need anything, and just providing a friendly voice for them. So we've been really happy and blessed. And that's something that I think we're probably going to continue beyond COVID-19 as an enhancement to our program.
Thanks again, Lisa, for sharing a prime example of providing choices at mealtime to improve nutrition and quality of life. And now we have another guest expert with us today, sharing her success strategies for elevating the dining experience in senior living. Suzanne Quirin is a consultant dietitian with a wealth of expertise in improving resident satisfaction. Suzanne, will you please introduce yourself and share a few effective person-centered strategies that you have seen in senior living?
My name is Suzanne Quirin. I'm a registered dietitian both in Canada and the United States, and I'm the inventor of the Suzy Q carts. That's working in over 1,000 healthcare communities across the countries. And I provide education and resource support to communities that want to change to person-centered dining. The second one would be is that food is only nourishing if people actually eat it. And as a dietitian, I believe that fully. So I think sometimes we need to actually step back and take inventory and understand why aren't residents eating it? Is it too much food? Is it cold? Is it what they actually wanted? Are they in a bad mental health space? So they're just depressed and feeling isolated, and so they're not wanting to eat? You know, what are all the reasons why someone may or may not be eating well? And so we can get really clinical about things, but we have to really look more bigger picture as to what's going on. And then the third one is shifting control from the staff predetermining for the residents what they will eat and drink and how much, and shifting that more to allowing the residents to do that. And how we can do that is moving away from tray service, away from pre-plating in the back of the house, and bringing the show to the residents with mobile carts. So you can get a beverage cart going, you can get a dessert cart going, and you can get a food cart going like a Suzy Q cart. So put the food choices in there, talk to the residents, ask them what they would like, and then serve accordingly. And guess what? Residents actually eat better when they have the food and beverages in front of them that they themselves actually want. So we need to abide by all our licensing regulations and all that sort of thing, which is important. But what a resident chooses is their fundamental right, and we need to respect that. So those are some examples to help.
Thank you, Suzanne. I love what you mentioned in your first tip, which was all hands on deck. The term protected meal hour is perfect. What a great goal to practice this in all care settings. Mealtime is about mealtime, plain and simple, and putting your management team to work during it is genius, as well as getting commitment from the entire staff to protect that meal hour. And your second point, food is only nourishing if they eat it. That's so, so true. And something we often say, but what are we doing about it? Hopefully, something. I like your advice to simply take the time to find out why someone might not be eating. Because you likely can't solve any mystery without investigating it, right? So, when it comes to person centered care in senior living, really understanding why each resident is not eating and how the resident feels about the dining experience is a key approach to reducing malnutrition and improving quality of life. How would your residents score your dining program? And you got skin in the game too. Put some pressure on yourself. How would you yourself score the program you are providing? Suzanne tells us a bit about both here.
Do an anonymous dining experience survey. So what would your customers give your dining experience? What is their top frustrations? And how do you really know? And I find that most food managers don't actually really know. They actually don't have current survey results. So you need to have some sort of system to measure how well, not just, did you like this meal, but the overall experience about that. And if it's done anonymously, it's going to be more honest. So you might need to mail it out to family members. You might need to do a survey monkey. There was a recent poll done by the Senior Dining Association that showed that 55% of communities do resident surveys. So that's about half. And I think we can do better than that. Most food managers actually give the dining experience score only as a range of 5.4. So if it's not a 9 or a 10, be open to some ideas today. And what I currently hear constantly from food managers is this: they're struggling with cold food. There's a lot of food waste, updating the likes and dislikes list, the poor customer service piece to the residents and their interaction, and the lack of choice. And choice doesn't just mean chicken or fish. Choice can mean, would you like that and how much? And do you want gravy on the side? That's what I mean by true choice. And that's what residents want. They want choice, they want proper temperature and size of the meal, they want to be shown dignity and respect by communicating directly with them. They to even talk to them, even if staff think that they're too confused to make a decision. And the research from the Pioneer Network proves that that is not true. Residents can still make decisions. We need to maybe change how we're asking the question and not to decide for them unless you haven't given the, like, first give them the opportunity to try and communicate and then make an educated decision if you can't. But good observation skills and collaboration really helps.
Wow, thanks, Suzanne. Elevating the dining experience for our residents with the goal of influencing improved intake can make a significant impact. You shared some great practical examples that we can use. To add to that, I want to remind us again not to lose sight during COVID. We know COVID-19 requires us to have restrictions and modifications in place for our dining programs, and that will likely remain for some time. We really encourage you to think about the creative things you can do to elevate the dining experience during this difficult time, such as using a mobile cart, like Suzanne referred to offer fresh choices to in-room dining. On these photos, imagine the servers have masks on. You can do this. Here's an example with staff wearing masks, getting out and trying to improve that socialization. And lastly, here's an example of a snack cart, another great way to increase self-determination.
Let's take a minute now to review the key points we've covered today. As we do, I want you to think about what your program needs and take a minute to prioritize some action steps for your team. First, the why. We've established that COVID-19 may increase the prevalence of malnutrition in adults 65 and over, which is a significant and growing portion of our population. We shared key stats showing that malnutrition increases the risk of poor health outcomes and raises the cost of care to the healthcare system. And that food and nutrition services leaders everywhere need to be proactive in offering creative, person-centered intervention strategies. How? Think about the factors from the acronym ACE when discharging seniors to home settings. Assess, screen for food insecurity, do nutrition-focused physical exams as appropriate. Connect, use your team members and your community resources to provide effective nutrition solutions that will influence improved intake. If your local resources are lacking or backed up with waiting lists, be creative and innovative. Work together to host new programs or host your own. Make it a goal to assure everyone has access to nourishing meals. Educate. Provide education, including usable tips that people can make informed decisions on a daily basis with. And in senior living, for the dining experience, always keep AAA in mind. Atmosphere, assistance, alternatives. And with alternatives, we're meaning true choice in where, when, and what to eat, so that you may provide an enhanced dining experience, influencing a lower prevalence of malnutrition, and therefore better infection control, better weight maintenance, fewer falls, fewer pressure injuries, and an improved emotional well-being, all resulting in high quality outcomes and 5-star ratings.
Thanks, Dana, for providing and sharing some creative ways to elevate the dining experience. And now let's talk about some helpful resources. Here are a number of evidence-based resources that are available in the industry. Please see the sites listed for Feeding America, Defeat Malnutrition Today, the Malnutrition Quality Improvement Initiative, Aspen, as well as the Pioneer Network. Dana?
Yeah, thank you, Amanda. And beyond those industry resources, Gordon Food Service also has a wealth of resources to offer you, our valued customers. Let's look at a few. First off, our menu software and menu customization is available to help you meet your goals and nutritional guidelines. We have dietitians available to help customize standard GFS menus to meet your needs. And then we want to call out Gordon Experience, which is www.gfs.com, and you log in with your username and password. If you don't have a username and password, you can get one from your Gordon Food Service sales rep. There are so many resources on this site for you, all sorts of them. Let's look at a few. First is our Food First page, ideas to help beef up nutrition intake for those who are not eating enough. And then we have our Teaching Kitchens page. It offers guidance on starting your own teaching kitchen that you can use in so many different ways to help people in your community learn how to do more in their own kitchens. We have a Memory Care page, a collection of ideas to help with nutrition for people with dementia. And one of my favorite, our WOW Waitstaff. This is a video and a handbook to help you train your staff to assure a great front of the house atmosphere. Another good one is our Senior Meals Menus page, sample menus for inspiration that you can use to help do your job. And Amanda, can you share about our white papers?
Yes, of course. So one of our best resources that we have available for our customers are the various white papers. Some pertinent ones to think about and to learn more about are the ones that are regarding malnutrition. Those include keeping an aging population healthy, building communities through food, and maximizing reimbursements with person-centered food and nutrition. These are available by reaching out to your GFS Customer Development Specialist. We also have a number of product solutions, such as our Tastefully Balanced To-Go meal program, along with our employee and family meals using our Gordon Choice entrees. Both of these options provide a great way to provide nourishing meals for patients as well as for team members. Dana?
And we can't close without talking about the Idea Center. We have so many articles for you to read on current relevant topics. And we also have podcasts and webinars. You can go under Solutions and then Culinary Resources, and you'll find both new webinars to register for, as well as recorded webinars and podcasts for you to reference. All of these resources and more are available for our valued customers. You'll see we also have on-site micro-market planning materials, recipe taste test forms, dining satisfaction survey. Just ask your Gordon Food Service sales rep for more information. And thank you for your time and attention. We hope we have hit some ideas for you that will help you make a difference in preventing malnutrition.
So thank you for listening today. Please be sure to visit all of the exhibits and navigate to the Ask the Expert area to find the It's Your Business booth. There, you can fill out a short evaluation and request a certificate of attendance for continuing education. Thank you again.
Thank you.